Firas.
Assalamu alaikum. Good afternoon, everyone. Thanks for the nice introduction. So I'm going to talk about the yes. And to start with, nothing to disclose other than being an addict. So I'm the expert in that field. And I will tell you how we'll counteract the effect of benzodiazepine. To start with, I need you to know my opponent. So my opponent sent me this message a few days ago. I know him for 12 years, and we are fighting for everything. So even if you say this is black, I would say, it's light black. And we are keeping like that. And for 12 years, we did not solve this issue. Is it 3 or 4, guys? What do you think? 3 or 4? 4? So I said 4. 3, I said 3. But he is the wrong person, always. So whenever we'll say heroin, what will be the antidote? Naloxone. Okay, good. And whenever we'll say benzo, no need for your presentation. Done. Good. So benzos, well known. We have them in oral forms, we have them in IV forms, suppositories, and they are used for a variety of situations. In our hospital, we are using them also in emergency department for procedural sedations, and even for patients with compulsion also, and for a variety of uses. Now, the issue with them, patients can come with you with intentional, and they can present it with iatrogenic overdose, which is usually the case with procedural sedation. And benzos abuse as a single drug, abuse is increasing in the States. Some of the studies, they are saying now that around 11% of ingestion is related to benzos. And mortality is increasing also related to that issue. This is where we have to be vigilant and to follow and to check if we can give any drug which will counteract the benzos. So what benzos will do mainly? What type of depression? Respiratory depression. Okay. So just keep this in your mind also. Now, Flumazenil, it was introduced in 1987, and in 1991 it was approved by the FDA. And this paper came in the Annals of Emergency Medicine a few months before the approval by FDA to say that it's a good drug. And they kept some recommendation or some suggestion to use it. So to start with, rapid reversal for benzodiazepine-induced sedation. The other one is as therapeutic role in management patients who have taken benzos overdose. And they said it could be a diagnostic and therapeutic for patients who don't know what they took. And I think till now we are talking about mainly number 1 and number 2 in our recommendations. Okay, so now these are the studies or similar studies that Muhammad is going to use from now. And I need you to find the common word among all these studies. Flumazenil in mixed benzos, TCA. Fatal seizure after Flumazenil administration in mixed overdose. And risk of Flumazenil in mixed benzos. What is the common word? They say it. Okay. So now I'm challenging Muhammad not to use the word of mixed or poly or multiple in your presentation. This is the second one for you. Good. Let's see now. And even the last study, if you can see it, it's in dog. So I hope he will not bring any studies in dogs. A fourth study, he will bring this study, but if you look in the abstract, it mentioned directly co-ingestion. So if he will use this study, co-ingestion will be considered also as a wrong answer from you. Do you need to present, or I will continue only with my presentation? Okay. So let's look now on the other side. All the studies we presented were small studies, and most of them were case reports. One of them was with a small group of patients, around 60. Let's look now on the other side. These studies, the first one is around 123 patients were blinded and into 2 limbs, and they found that it's safe to use it even in mixed ingestion. The other one, for 320 plus patients, and they also divided them into 4 groups, and they found it's safe to be used. Another one, it says that the most common side effects is some sort of anxiety, crying, and some emotional upset. So it is not the convulsion which we are talking a lot about it. Okay, what's good about it is that if you use it as a procedural sedation, it can decrease the time needed for the patient to be monitored even. So you'll need around 14 minutes instead of 30 minutes, which is good for us. A risk-benefit analysis, which was done also in the Drug Safety Journal, states that you can use this drug in usual patients. You need to avoid it in patients with renal failure, with liver failure, but you can use it on regular patients. And usually, you need to take precaution in patients with TCA. So if you have a pure benzo, you can use it or not, you can use it. Now, it seems that even it reduced the length of stay in the ICU, and also it reduced the cost of hospitalization. So let's fight more. I know what he will say now. He'll say, yeah, but there is a risk of convulsion. And our problem with the convulsion is that it is benzo's resistance, so it will not respond to benzo. Even that, we have other solutions, so we can use other weapons like propofol and barbiturates, which you can use it, plus minus intubation and ventilation. Okay, so where you will use it, remember it. Benzoiatrogenic overdose, procedural sedation patients. Overdose, accidental ingestion by pediatric especially. These, I will call them naive, so they are not like me. They don't use it every day where there is a risk of convulsion. They don't have TCA with it, so these patients, you can use it for them. I will say not to avoid. If you will avoid in patients with the QT prolongation because they have sodium channel blocker property, and you need to avoid it in these patients, the TCA patients especially. Okay, who is the winner? Does he need to present or no need? Thank you very much.
Hello, Ahmed, go for it.
Thank you, Firas. That was very entertaining.